All right, good evening. I'm Maddox Casey, and this is Say Evans, and this is number 3 of 5 in our Physician Summer Seminar, sponsored by Southern Medical Association, Southern Medical Services, Warren Averett, which is where Say and myself are from, and the Jefferson County Medical Society. So we appreciate you tuning in. We have a large crowd in-house tonight. No camera here, but if you could see us, we got the room packed out tonight. So you're missing out if you're listening on webinar tonight. And before we go there, I'm going to pull up this slide that has my information, Say's information. And as always, if you have a question that during the seminar and you're on the broadcast, feel free to email me or Say. Don't call us because we won't pick up, but email us a question, and we will look at those questions as we go and address, if we can, address your question at the end of the seminar. And of course, if you have a question that comes up after the seminar, or if it's related to one of our previous seminars, or any question that you think we could help you with for your practice to manage more appropriately, feel free to email or call us even after the seminar. So I'm going to leave that slide there for just about 10 seconds for you to write down our information in case you need to get with us. And we'll pull this up at the end as well if you can't see it now. Well, tonight's number 3, and we've covered in our first seminar, if you haven't been with us, we've covered buying and selling a medical practice, which is available on SMA's website, and we've also covered practice profitability. Tonight, we're going to cover 2 topics. The first topic being accounts receivable, and then the second topic labeled compensation and how to design your compensation structure in a manner that is congruent with current reimbursement models and is also advantageous for your practice. So as we jump in, our first sheet that we're going to look at is a sheet that we actually use for most of our clients, and we think is a good sheet, a diagnostic, a benchmark, a pulse, whatever you want to call it, of your practice, of your accounts receivable comparison, and your production and your collections. And as we look at this, we usually begin with accounts receivable and an aging analysis. And we're looking at 0 to 30 bucket, 31 to 60, 61 to 90, and over 90 buckets. And those buckets are telling us where we stand in the number of days, obviously, outstanding for our claims that currently exist. And we'll back up for a minute and talk about the current environment. We've talked about this already in the first 2 practice profitability series of what the Affordable Care Act is currently doing to our collections in our practice. And Say and I have already taken numerous calls from many of our clients on our accounts receivable. And what we're seeing is that with higher deductibles, and this is a quick recap, higher deductibles, exchange products inside of the state, if we don't have the proper collection systems in place, the first place for that to rear its ugly head is in the accounts receivable. The aging is beginning to age out quicker. We're getting bigger balances in some of our bigger buckets, and our later buckets are 31 to 60 or 60 to 90. Our overall total AR is also growing as a percentage year over year, and that's because patients are showing up with larger deductibles, larger copays. That they aren't willing to pay. They have insurance. They know they have insurance. They're just not used to larger deductibles and larger copays. And that's not just our exchange products. That's also for some of our clients who have insurance and have had insurance for many, many years to their employers. Employers are beginning to make decisions of either paying higher premiums for their plans or bringing their plans back down, what we call metallic plans. Those are the platinum, the gold, the silver, and the bronze. If you used to have a gold plan, which in Alabama used to be a Blue Cross 320 or 350, now you may have to pull that back down to a silver plan. That's going to raise your deductibles. That's going to raise your copay. That may be the only equalization into getting the same premiums as you're currently paid. So our patients, your patients, our clients' patients are all presenting with higher copays and higher deductibles. This is the driver behind our accounts receivable. So inside of this diagnostic that we're looking at, this accounts receivable comparison, we're looking at, and these are old numbers, irrelevant numbers, but we would be looking at them is a snapshot for the last month that we can look at. So we would be looking at, let's say, May 30th of 2014 versus May 30th of 2013.
And for a lot of our clients, when we meet with them at year end, this may be the only time that they see their AR. And and that's, I'd say it's okay, but really you need to be looking at this every month if possible. Get a report. Our clients can call us at any time and we can run a report like this and review their AR with them. And if you're not looking at your AR on a consistent basis, I mean, you can't manage something that you're not monitoring. So if you're not monitoring your AR, I hope after we have our talk today, you'll see how important it is and you'll keep your eye on it.
Yeah, I agree. I mean, if you haven't looked at it, you can go pull it from your practice management system. Get your billing manager to pull it from it. Get your office manager, your administrator to pull these reports and bring them with your financials or at your monthly meeting, and look at them during that monthly time period, because it can get out of control very quick with the current environment that we're in. So as we look at month-to-month comparison, we're looking at irregularities inside of the numbers. We're looking at large increases or decreases that are sticking out. So if we look at this one right here, we can see that if you go to about the third column on this sheet, you can see an increase of about $61,000 in the current bucket, 0 to 30. We think that's fine. That would be fine under this analysis. That probably means we're working harder. There's more money sitting in our current dollars. We know that those monies are going to be received.
And especially if it's an insurance balance, it could just be the timing of a deposit, or receiving that money on December 30th compared to getting it. This year you might receive it in January 3rd. So, the cutoff may be causing that difference, and it's important to look at it month to month and not just once a year.
Yeah, we would say that most of these monies for most specialties are somewhere between 90 and 95% collectible. There are going to be some write-offs in the 0 to 30, but as we move down the aging, in this example, 31 to 60 grew by $4,000. We need to determine where that $4,000 is attributable to. Is it insurance or patient, like Say talked about? As we move into 61 and 90, this would be a little more of a concern for me, that we're moving from $55,000 to $42,000. This is a $12,000 increase, and then actually over 90 looks okay. So I might excuse that some of this bucket got dumped into the 61 to 90, and that the overall would be fine. As an overall total, it's up $65,000. Most of it, $61,000 of it's sitting in current money. In this example, it's fine. We have seen examples, and we continue to see examples of the total AR moving up $100,000, $200,000, $300,000 for time period, and the money keeps shifting down the buckets. If that's the case, the alarm should be going off. Something in your head should say, I need some help. I need to figure out why is it going up. And that's your next step. After you've looked at that, below that, and Say alluded to this, insurance balances versus patient balances. Where is our money? Where is it sitting? Where does the problem exist? If it's in insurance money, our normal diagnostic would tell you that someone needs to probably go work some claims. If we have a lot of money that's sitting in insurance balances, and we're looking like over 90 in this situation. So we may have denied claims. We may have claims that need to be reworked. Zero balance claims. Why is our money in over 90 not being paid from our insurance? Because this is gimme money for the most part. Besides, if you've got something held on a Medicare or a commercial government contract, your commercial payer should be paying in 15, 20, 30, at the most, 40 days for most of your commercial contracts. And I'm talking primarily about the state of Alabama, but even commercial payers outside of the state of Alabama are usually quick payers.
And if your insurance balance is over 90 or high, you need to figure out why. Is it because you're coding you're submitting your claims improperly? And then you also need to look at your denial rates and also your appeals and see how successful you are in getting those denied claims paid when you file them again later. So it's really important to look at your insurance balances over 90, because that balance should be very low.
Yep. And then our next category is patient balances over 90. This is where we've seen the largest increase in the last 5 months, is in the patient balance bucket. We've seen the high deductibles, copays, as we talked about. And if your large increase is due to patient balances over 90 days, you probably have a collection process issue. And we're going to get into that a little bit later on, of how to resolve collection process, how to have a great collection process. But patients are either abusing the process, not paying it, or you don't have a process. There's one or two or three things that this could be the problem of why your patient balance over 90 days is increasing at a rapid rate. Next is your days in AR. Days in AR is just the easy definition of days in AR is how many days does it take for us to collect our money since the day that the claim was filed to the day we received the money. And 28, 25, these are great numbers for this practice right here. I would tell you anything under about 30 is a great number. Anything over between 30 and 40 is still okay. Depends on your specialty, depends on your payer mix. But once we get over 40 days in AR, this is a good indicator of how long it's taking us to collect our money, our cash flow is being decreased, and especially if you see a large change between year to year. If it was 25 days last year and now it's 35, that's 10 days of money that we're missing out on. That's our cash flow is becoming a little more crunched on. We need to work out. And I would say most of the time, if your days in AR have gone up, one of the first indicators that we just talked about, it's probably glaring at you. It's probably a total AR issue. It's probably an over 90 issue that we've already seen in these first couple things before we get to days in AR. So definitely will drive it. What we didn't mention at the top, if you look here, I think it's important that you benchmark yourself against against the same people in your specialty. So you can see here on the far right at the very top, we're using MGMA average for the specialty. We see that 47%, 13.65%, 8%, and 31.57% respectively for those categories. If you fall way outside of the benchmark period, we need to figure that out as well. And that's just an easy number to compare yourself with against other people in your own specialty.
Regardless of what specialty you're in, if you're over 90, makes up 25% of your AR, you've got some kind of problem. You need to get that checked out. And you look at this MGMA average, it's got 31.57% over 90. So it looks like on average, a lot of the population that submitted their data to MGMA has an issue. But when we see a practice that has 25% over 90, we generally can pretty much guarantee there's some kind of issue there that can be improved upon.
Yeah, and I don't remember what specialty this is right here, but that does seem a little bit high for the over 90 to be at 32%.
Yep.
As we move down the sheet, we have put production numbers on this AR page, and a lot of people ask us, why do you put production on the AR sheet? So why is that even relevant? You know, how do these two tie together? One reason they tie together is that there is a possibility that you are collecting last year's money, and that's why your AR has decreased. So in this, or vice versa, your money is not being collected yet. It could change your AR. So if we look down here under this category on the current year, you can see net charges were $2.688 million. That's the amount of charges that got dumped into the AR system. We collected very close to that amount of money, $2,646,958. So in between those two numbers, the delta change between net charges dumped in the system and collections is $40,000. That would tell me that of the number made up at the top, the difference between last year's 383 and 448 this year, we should see about a $40,000 increase in our total AR just by the amount of charges that went in the system versus the collections. Now, sometimes we'll see at the bottom there, we'll see collections of, let's say, 2.8 million versus 2.6. So you could have someone telling you in your practice that AR looks great, that it looks healthy, that overall your total AR is down, and they were collecting more money. But if you've collected more money than charges have gone into the system, you're just collecting last year's money. It's really not moving the ticker on your total AR. So that's why we put this program here. That's why we put this production here, because oftentimes it's a telltale sign of what's going on inside of the AR.
You know, you mentioned total AR. We very rarely look at the total AR without looking at the aging, you know, the 0 to 30, 31, 60, because total AR really can't tell you a whole lot unless you're looking at those aging buckets. I mean, you can look at if it's increased or decreased from year to year, and the only time your AR should increase from one year to the next is if you add a new physician.
That's right.
That would be the only reason it should increase. If your AR decreases, most likely either your billing group is doing a good job, or either you've scaled back your patients, or you've lost a doctor. But even if your AR is stable, that doesn't necessarily mean that things are okay or that there's no issues with AR. So I just wanted to emphasize that total AR, you can look at that number, but it's not an indicator that you should rely upon to determine if your AR is a good balance or not.
That's right. And the other thing we can look at here is just go ahead and look at a snapshot of production for physicians. I mean, we can look at how much of our full fee schedule, our gross charges, are we collecting. Here we're collecting 50% of it. That's pretty normal. And then we can also look at the amount of collections as it relates to net charges, and see how we're doing for the year, collections versus net charges. We can look year to year and kind of tell overall as a practice. You can see here they had an increase of gross charges of $280,000, which resulted in net charges of $60,000 and collections of $60,000. So it's a pretty good indicator year to year without even looking at a financial statement, without even pulling a collections year to year. We could tell you right here, this is collections year to year. We could pull it. This is pulled from our practice management report. We could tell you exactly what your financial statement should look like when it's being pulled for this time period. One of the best numbers on this page, the most telling numbers on this page, the number that most physicians want to look at is how am I doing against my peers? And here we're showing, this is for 11 months. We show it 4.4 physicians. That's how many physicians were in this group. And you asked 0.4. No, nobody was worth 0.4. It just happened they worked about 5 months out of the year. So we put it into a pro rata number to make sure that it's a proper comparison. So for this group, if we were looking at it in a meeting with them, we would say you collected $2.6 million versus the MGMA average of $2.3 million. You're just above average. And that may make you happy. That may not make you happy. Just depends on your personality of where you stand. But at least you know where you stand. The other thing we do for a group, and I think you should look at, is not only look at MGMA averages, but if your advisor has some information related to your area or your specialty. We have that ability to pull, let's say, an OB-GYN numbers. We use our internal data without using names, and we use kind of what we call an Alabama average for OB-GYN, because the national MGMA, which is what's represented at the bottom, can be skewed by different markets. Different markets are going to make different amount of money. So when we would pull that number for Alabama, we could tell you what your counterparts in the state, in the city, are making as it relates to your own collections and how you compare.
Mm-hmm. MGMA has a national average. It can also have a regional average, so you can get the Southeast. But even better, like Maddox is saying, is do you have someone in Alabama? Or even better, do you have someone in Birmingham that you can compare to? That's what the physicians we work with, they really like to see, especially just in the city. How do I measure up with folks that are in my same specialty? Yeah. So that's really valuable, good information to show when we have our meetings each year with our physicians.
The other thing that usually comes out of this conversation when we talk about AR, we talk about production, collections, is if you fall in that range and you're below average, but you are looking us square in the eye and saying, I'm working as hard as I can possibly work, I'm doing everything I can, I get there at 7:30, I leave at 6:30, something's not adding up. There's something that's not working. Either you're not seeing patients fast enough, either you're not billing for all your charges, either you're undercoding for your ability. There's a lot of signs that can happen just by this one number of where it stands. You may have another issue, and we've already been into some of these issues on practice profitability of what's going on. Are you spending 45 minutes with a patient when you should have spent 25 minutes? Your counterparts could be working less than you, but seeing double the amount of patients or a third more amount of the patients, which is resulting in more dollars in their column. So this tells us a lot, and your take on how hard you're working as it relates to other physicians. All right, so we went through most of these dashboard indicators. These are just some notes for you to have if you're listening to this webinar at a later time, or just if you wanted to print out these slides. Just some notes here of what days in AR represents, total production divided by 360, production per day. And we also talked about the AR divided by production per day gives you the days in AR. So just if you are looking at these sheets later on, and I forgot what 8 days in AR, how to do that calculation, here's the cheat sheet for you.
The days in AR, if your practice mainly sees Medicare patients, Medicare pays like generally 14 days around there. So if your days in AR is anything over 30 and you're mainly a Medicare practice, you probably need to re-examine that. Your Medicare practices should generally have a little bit lower days in AR compared to other practices that see commercial and other payers. So that's just something to keep in mind if you see primarily Medicare.
We talked about the year-to-date collections, and we talked about how it's important to compare yourself year to year to others and your specialty. We mentioned Alabama here. Of course, that's going to be true for any other state if you're not practicing in Alabama. The last line here, say, begin this conversation of would the real AR please stand up, and how do we eliminate the distortions in AR? There's some other factors. Say mentioned you bring on a new physician. Well, our AR should go up. You take a physician out. Well, your AR should go down. Those are some easy ones. Some of the other ones that you wouldn't think about is, let's say you have a billing manager that is being looked at or on their AR, and they know that we have a bunch of bad old AR over 90. And they know that we as the accountants are about to pull that information and ask for those reports because we ask for it every year in November. Well, the easiest way for them to look better than they are, because they're not working the AR, is just to write a bunch of it off over 90 and just completely disappear the over 90. So we've got to look at and make sure that didn't happen between those two time periods. It may take some further investigation into the matter to make sure that we're really looking at the real AR. Will the real AR actually stand up? The other point here is the beginning point is having a valid AR to work with. So you've got to have comparable data. You've at least got to have 1 year of verified real AR. You're just a first year of practice out. It's going to be a little more difficult to look at a month-to-month comparison. It needs to smooth it out. We need to work out the irregularities between the AR when you started your practice, and if you're ramping up, if you're getting more and more practices, it's going to be more difficult to compare your AR. You could use percentages for your aging, but necessarily the totals may not make a whole lot of sense. The other part here is how do you treat credit balances? Credit balances are those balances where, let's give an easy example of an OBGYN collects the $500 copay for having a new baby on the front end. That gets booked into the AR already because we received that money, and now we have a credit balance. We have a negative balance inside of our AR. Where is that showing up on our reports? And usually it shows up in current, but is that showing up in current? Is it distorting our numbers? The other part is just flat out credit balances if you don't work your credit balances. Now, credit balances are a patient shows up, we tell them they have a $50 copay, and they owe us an additional, we're running instant eligibility, and they owe us additional $300 on this procedure they're about to have. We put the money in there, we apply it to the patient account. When we run the insurance, well, in reality, that was wrong. Either the insurance was wrong, we didn't have the right amount, the patient only owed about $200. Now we owe the patient $100. That's bringing our AR balance down. We owe the patient $100. What you should be doing as a practice is working those credit balances. You should be finding the patients, sending checks out to patients, refunding the money. A lot of people have a real difficulty doing that because it's hard to part with that money, but technically you should be letting go of that money and giving it back to the patients. The only example, or the best example I can give you, is we walked into a practice about 4 or 5 years ago, and AR was messed up. It was just out of whack, and we asked to see the credit balances. And we figured out that the credit balances were $500,000 owed to patients. They have never been worked. Patients were owed so much money for many, many years, and we said we've got to begin working these patient balances. If they're not legitimate patient balances, they call those ghost charges. We need to work those out. We need to issue checks to our patients and make sure that we can get the real AR and have at least a valid starting point so that we can compare next year and we're not working with these credit balances. Of course, the state of Alabama requires that if you have a credit balance, you get this little blue notice every single year. It asks you to report them as unclaimed property. So even if I give you a check, I owe, say, Evans $90 for his visit. If he doesn't cash that check and it's outstanding on our books, you're supposed to remit that money to the state of Alabama as unclaimed property. And therefore it sits outside, which we kind of jokingly laugh about, and I know this is recorded, but the practice doesn't get to keep the money, but the state of Alabama just gets to keep the money from years upon years upon years upon years, because most people don't know about unclaimed property. If you don't know about unclaimed property, just a tidbit tonight, this is free. right here, free advice on unclaimed property. You should probably go to the state of Alabama's website and Google unclaimed property, state of Alabama, and type your name in and see if you have any unclaimed property. I had a client recently had $5,200 in unclaimed property. It was a real estate, it wasn't even medical related. It was a real estate transaction where the money had been put into escrow and they couldn't find them with the wrong address, and the money was sitting out with the state of Alabama's website. So when you do that, go pull your relatives, put your wife's name in there, put your kids' names in there, your father-in-law, mother-in-law, and if you find somebody, you can tell them. And
tell them to give you a cut of it.
Tell them you found some money for them, but only if they give you 30 or 40% of it will you tell them where the money, the treasure is hidden. So it's a neat exercise. Sorry I went on a rabbit trail there for a minute, but there is unclaimed property, and that's the technical way of reporting unclaimed property, your patient credit balances, to your respective state. So we talked about AR. We've been through our AR spill here, and now we're talking about good procedures if you expect to be paid. So we're going to talk a little bit about the right thing, the right way to handle getting money so that our AR doesn't drive itself up. We talked about the current environment. We talked about Affordable Care Act. We talked about patients with higher copays, deductibles. You need to have a proper procedure in place to be able to collect money from patients. If you don't have a sign on your door already that says something like copays and deductibles are due at the time of service, that's an easy gimme. You should have that up there. Your patient should expect to pay copays and deductibles for the services that you're about to render. You work hard for your money. You've been to many, many years of medical school. They're there to see you. They've booked their appointment. The days of when you could come through the practice and see the physician, come out the back door and say, just bill it to me, should not exist in medical practices anymore. You have about 5 times to collect money from when the patient begins the procedure. When the patient calls to book the appointment, the proper procedure is to get their information, and you should be getting their insurance information at that time. If they're not checking in through a portal on your website, you should be getting their insurance information and validating that insurance at that point. If it's for an office visit, you should know at that point what their copay is if you can run the instant eligibility. You should say, Mr. Jones, I know you're here, you're booking an appointment on April 3rd, and at that time, please present with $50 to pay your copay. The second time that you have the opportunity to collect money is when the patient calls back, and when you call them back, is a reminder appointment. Mr. Jones, I'm confirming your appointment on April 3rd. By the way, please present with $50, cash, check, or blood, one way to pay, not blood, cash or check, a credit card, or whatever way we take to pay your copay at the time of service. Your third opportunity, when they present in your office. Mr. Jones, thank you for showing up. Here's your paperwork, fill it out. By the way, I need to go ahead and collect your money of $50 before you see the physician. That's your third opportunity. Your fourth opportunity, whenever they're done seeing the physician, and you can see where I'm going here. The farther we get down the trail, the less likely you are to get your money. You're done with the physician. They've already been rendered services. You know, at this point, we're on number 4. They're less likely to pay. They're less likely to come up with some excuse, some method. I left my wallet in the car. I don't have any money on me. You know, my child's got a baseball registration I got to pay. They're going to come up with every excuse you can imagine as to why not to pay that copay before they walk out the door. So that's our fourth opportunity. And then, of course, your fifth opportunity is your statements, your bills that you're sending out. And as we move farther down that chain, if you haven't already established the procedures of what you're going to do with a non-paying client, your percentages are dropping every single time as we move down that chain. And if we get to the statement balance, at that point our collectability becomes less than 50%, arguably less than 25% to actually receive that money. So there are some proper procedures to do it. If you don't collect your money, your whole staff needs to be on board. Your front desk needs to be on board with your back office that we're not going to see that patient unless it's emergency care, unless it's a situation that we actually have to see the patient. Thank you for showing up today. It's $50. I don't have it. I can't afford it. You know, all the excuses that we see. And matter, we'll reschedule you for a time when you can pay. Your front office has to be on board with that. You may even want to incentivize your front office to do procedures in that manner because your front desk person doesn't really have any incentive to actually collect the money unless they're just a great, loyal employee to you. But if we can incentivize our front staff to, let's say we want to collect 95% of our copays and deductibles at the front office and put them on that benchmark, and we'll treat them to a party or there maybe even a bonus if it's $50 a month. It will be well worth it if we put them on the same page and have an incentive to actually collect our money. On the backside of that, on collecting money on the backside, if they do happen to get to our checkout person, if we have prescriptions, if we have something that we can hold back from them, we're not going to hold it back from them, but it's the manner in which we receive that money. Not, will you pay $30 today? That's the wrong language. How will you pay $30 today? Will it be check, cash, credit card? Will and how are one little word, separates the two, but our collection procedures can be a lot different. The other part of that is putting the right personality, and we could talk, until 7:30 Central Time about putting the right people in the right place, but the right personality has to be at the back desk, and not your personality who knows all about the grandkids and talks to the patients and is just nice little sweet, typical back office checkout lady. That's not going to work very well. They will be highly manipulated. They will be miserable trying to collect money. We're looking for that personality that's got some strictness to them. We call them a high D personality, who's got some domineering to them, and the fact that, hey, I'm going to get this money. You owe me this money, and you're going to pay today. I know you've got every excuse in the world, and I know there's exceptions to this rule, but you owe us money. We need you to pay us today. How are you going to do so? If you put those procedures in place, if you put the right people in place, the right personalities in place, your AR, your accounts receivable, even in light of the circumstances that we're currently sitting in, the Affordable Care Act, the high deductibles, high copays, you should be fine. We should be able to collect that money.
Another good thing to do is when you hire someone new that's going to be in a position to handle money or work in the billing area, is do a background check and just make sure that you're comfortable having them in that position. And then if you've got a couple people working at the front desk, handling money, doing the billing, cross-train them on each other's job so that if somebody's gone, that person can then pick up and do the same job, do both jobs for a period of time, and also force those people to take vacations. That'll help minimize and reduce the chances for fraud and embezzlement in your practice, especially when those individuals are handling money. So those are just a few things to keep in mind with your staff that are doing billing and handling money in your practice.
Yeah, I love the vacation point. People forget that if somebody hadn't taken vacation and refuses to take vacation, it usually means they're hiding a procedure that somebody else is going to see while they're on vacation. It's a good point to force them to take extended period of time, not just 2 days at a time, because they can hide it for a couple of days. But you will take a 7-day vacation. You will be away from this office for 7 days. And we've seen some fraud cases where that's been the situation, and they didn't come back from that vacation. So that's a great point to note on your billing and on your receivables. We talked about the right people, the insurance money, collecting patient money, how to work those claims, how to collect the money from the patient, the right personalities, the right procedures and methodologies to actually collect the money from the patients. And that's really our accounts receivable section. If you do those things right, if you watch the dashboards, you watch the indicators, keep an eye on your aging, keep an eye on your total AR, monthly, quarterly at least. If you're annually, that's better than none. Some people aren't even watching this, but watching the financials, it will prove to be valuable to your practice as you move forward in this current environment. So our second part of our presentation tonight is dealing with compensation models and what type of compensation model fits your practice. I will say, as kind of an opening comment to compensation, almost every practice has a different compensation model. I don't know that I have a single client that has the same exact compensation model. Everybody wants something a little bit different. It works a little bit different for everybody. Everybody's got a little bit different personality inside of the practice. Everybody wants to split maybe one thing one way, one thing another way. And so we're going to look at just 4 or 5 tonight quickly and talk about how does it work and what's going to work for you going forward and what would work for you right now.
Yeah, there's no perfect compensation model that's going to work for every single practice. And even if you have a compensation model that works for your practice, depending on what changes go on with your practice from year to year, that model may not be appropriate 3 years from now. If you've added physicians, if you've lost physicians, if certain payer mixes have changed or responsibilities have changed within the practice. So compensation models are something that need to be reviewed every year to make sure it's still appropriate in accomplishing the goals and appears to be fair to everyone in the practice. And fair, is a subjective thing. I guess what we generally joke about is as long as everybody's equally unhappy, then it's probably a pretty fair compensation model. So, that's kind of the way it seems to work with a lot of practices. Is you can't always make everybody happy, but as long as everybody can live with it, it seems to be a pretty good compensation model.
Yeah, and Say's right. As you expand and get bigger, what was working for a 2-man doc practice may not work for a 4-man or a 5-man or a 6-man. If you're 2 docs looking equal production, we're going to split everything down the middle, split the baby in half. That works, and that may work for a long time. But if we bring in, doc 3, doc 4 that aren't as highly productive, or maybe even more productive, our split methodology may not work. I would say that more practices break up, and because of one issue, the compensation issue, than any other issue that I can think about. Of course, we're dealing with your money and how we split your money, but it's usually the breakup part between a practice. So as we look at this, we're just going to talk about 2 or 3 models that work and the different methodologies behind those models. In this model right here, we look at total collections per the AR reports, so how each physician has produced individually. This is a complete eat what you kill formula. And I'm not going to go down every single line with this, but you can look at it at your nighttime reading time if you'd like. But your collections per your AR reports, every doctor gets his own money. But line 2, they equally split all the money between in this case a CRNA and a non-owner. They each get their equal percentage of that. In this case, it's 25%. Down below that, there's some other income. There's some other prepayment of some other items. We're not going to look at that. But if you look about 12 lines down, net collections per the GL. So every physician is getting their equal share of non-owner and CRNA, their own collection pulled from the production report for the cutoff period, and that's what's represented under net collections. This model, this practice, is what I call a fixed model. It's all the overhead is split equally, regardless of production, regardless if you produce $1 million or $100,000, you're still going to pay your equal share of operating expenses. You can see under this model, each of them have paid $251,000 in operating expense, which leaves a net available for each of the physicians. Now, what I say is mandatory, and maybe Say would disagree with me, is that physician-specific expenses have always got to be broken out for each specific physician. And here we have salary, malpractice, payroll taxes, retirement plan contribution, and some other specific expenses. And the reason that's fair is if Dr. A, Dr. 1, wants to take a CME to Hawaii, he shouldn't have the benefit of spending all that money at the expense or cost of Dr. 2. That item should show down in specific expenses. If Dr. 1 wants a $150 cell phone bill and Dr. 2 needs a flip phone $30 prepaid Go plan, he shouldn't have to pay those expenses. So there are items that even operating expenses are considered split equally that should show up below the line. Same thing with malpractice. If someone has a higher malpractice premium, they should pay their own malpractice. Payroll taxes. If you're getting paid more, you should pay more of your own representative payroll taxes. Retirement plan contribution. If you do have a cash balance plan, if you do have someone who has not met the maximum of this year, I think it's $260,000, they shouldn't have to pay everybody else's retirement plan. So those numbers should always show up in their own physician expenses. In this case, net available for physicians in the middle of the page, back out their physician expenses, we get their profit. That is their bonus. It's as simple as that. We call this a completely fixed model, all operating expenses. The pro to this is that it's really simple. Everybody has a decision into what's happening with the operating expenses. The con to this is that oftentimes the higher producer gets the biggest benefit here because even though he's utilizing more of the operating expenses, let's say medical supplies is one that usually pops up, he's only having to pay his or her equal share of that operating expense.
Yeah, Doctor number 2 probably really likes this model.
Yeah.
And Dr. 4 if they're paying attention to this compensation model, may not be as happy about it because their overhead burden is as a percentage of collections is a lot higher than doctor number 2.
Yeah. So this is a strict eat what you kill formula with a fixed overhead allocation. Now in our next example, it's a little bit different, and you can tell by the titles or the description on the bonus what type of specialty we're dealing with here. This is an OBGYN, obviously. And this is one of those one-off kind of situations. OBGYNs are a little bit different because they take call, and they take call for their partners. So a lot of OBGYNs argue or disagree or agree on how the money for that global period payment, so you get paid for delivering a baby at the time of delivery, how that should be split. In this example here, we're backing out all the OB. You can see it about line number 5, remaining collections split evenly, that $289,000. We split that evenly. That's the money related to OB. They say, hey, we take equal call. We're going to be in there equal amount of time. We're going to split all the OB revenue equally. Anything that's not OB, so all our GYN, all our clinical visits, we're going to still give an eat what you kill formula. Everybody's going to get their own individual collections as it relates to GYN. So at the top, as we work our way down, you can see total collections. One doc is at $615,000 and one's at $506,000. Individual GYN, split OB charges. Now what this does for expenses that the last model didn't do is that we kind of call this a hybrid model. The hybrid model is that we're going to pick out 5 or 6 or 7 or 8 or whatever's agreed upon. Everybody's unequally happy on the variable expenses. And these items are going to be related to production only. So the more you produce, the more you're going to pay these variable expenses. And the reason we pull these out is we think these items are the ones that they should pay more of. And employee insurance, laundry expense, lab fees, salaries, payroll taxes, you can see them there. All of those, the more you work, the more you're using those resources. So the more you work, the more you're using of the staff. That's why you should pay more of the salaries. The more you work, the more you're using the medical supplies. That's why you should be paying more of the medical supplies. And then everything else that's left over is completely split 50-50. And the reason I like this model, this is my preferred model, is that rent stays the same regardless if you're there or not. We should all pay an equal amount of rent. That's why rent doesn't show up on the variable expenses. And that's why this accomplishes a portion of variable and a portion of operating expense. It doesn't let the high producer completely get away with paying the least amount of expenses, but it does give them the ability to pay a higher percent of the variable. This is operating expense. I've already gone on my tangent, my rabbit trail about physician expenses. You can see here, they even picked out a few other items that the last people didn't pick out, which is like business licenses and permits. They also picked out some travel. I mentioned CME, travel. They list all those items below. And then at the very bottom, there's their respective bonus. In this case, Doc 2 did not do so well, and he's got a negative bonus here. And I think we should talk a minute about what that does and what happens when you have a doctor and a negative bonus and how that should be taken care of. In this environment, we've seen it more often than we had in the last 3 or 4 years when a physician isn't pulling his weight and they have a negative bonus. What happens when a physician has a negative bonus is really there's only 2 ways to take care of that inside of the practice. One, the practice to pay the full bonus that's owed to Doc 1 will have to go borrow money because there's $34,000 worth of net income here, but doctor's owed $77,000. Doctor 2 has already pulled out more cash than he was owed. We may have to go borrow money. The other thing that could happen here is that Doc 1, there's only $34,000 worth of cash. He's owed $77,000. Well, he may just have to take a $34,000 bonus if they don't want to borrow cash. Doc 1 has financed, without any interest, Doc 2's specific expenses, his salary, his travels, his dues. There should be some conversation about this. You should have something in place inside of either your operating agreement that if someone goes negative, they shouldn't receive a salary moving forward until they recoup that negative. A lot of people don't have that built in because it hasn't been a problem in the past. But as we see declining reimbursements, increasing expenses, this becomes more and more of a more common problem that we're seeing.
And you need to pay attention to how often the bonus is calculated also. Because if you have a situation where a physician is constantly in the hole going negative, you may want to shorten the bonus period to a month or every 2 months or every quarter if you normally only do it annually or every, or twice a year. So you can keep track of, even if they're not paid, just have the calculation computed so you know who's going negative and can keep up with that and make adjustments as you need to.
And we will kind of go off course here for a minute and talk about how do you incentivize physicians that are not owners, and what kind of structure can you set up for them? We see a couple things. One, and the easiest way to set up a compensation program for a physician that's not an owner, and we talked a little bit about this in the buy-sell in our first seminar, is to produce a model that pays them a base salary of, let's throw some numbers out there. Let's say they produce $500,000 in collections, and we can look at that and determine what that's going to be based on their production report for the prior year. And if you don't have their production report from the prior year, they're a new physician, you can get a pretty accurate picture by just gauging what the benchmark is for an MGMA or what you're doing as a current physician and what's going to be their patient load when they first come in. But if they're going to produce $500,000 and we want to pay them a $100,000 base salary, well, that's fine. We could just pay them a $100,000 base salary and never have any type of incentive program for them. Come into our practice, work 8 days a week. 8 hours a day. 8 days a week is going to be rough, and it's 8 hours a day. Well, if we had them working eight days a week, we can really make money off of that guy. But 8 hours a day, 5 days a week, maybe even 6. The problem is that they're not incentivized to see 1 patient a day or 10 patients a day. They don't really have any incentive to do anything more than just sit in there and make their money. We would tell you to begin to have an incentive program that pays them a percentage of collections over a threshold. That's usually orchestrated and designed in a manner that we make enough collections to pay overhead related to them. So if our overhead is 20%, well, then we would pay them $100,000. We would make them collect at least $500,000. So we've covered our overhead there. Sorry, that'd be overhead 80%. We've covered their overhead, and then we're going to be able to pay them a percentage over the threshold. We'll pay them 20%, 25%. It depends on your practice. It depends on your profit margin. It depends on your operating expenses, on what that percentage is going to be. But a common number is, once we reach over a threshold, we'll pay you 25% of collections. The good thing about that is that it incentivizes them to go see patients. It incentivizes them to work hard. It frees up our schedule as the owner. It's a good succession planning tool for if we want that physician to, eventually own the practice. And it's a very simple calculation. It's easy because you can show them, if you have the office manager or the billing collection, that you can show them month by month where they stand. So if they get to month 10 and they've already met the $500,000 threshold, we mentioned this earlier, they will work like a dog for months 11 and 12 because they know that every patient they see, they're receiving 25% of that money in their pocket. And so it's a very easy way to incentivize them, an easy way to give them a number.
Hey, flip to the last slide. This is actually an example of a employed physician. This physician was not an owner of the practice, but it pretty much illustrates what Maddox was just going over. It starts off at the top with the physician's gross production, and it is then reduced for the personally performed portion of that physician's collection. So the base for the compensation is 90% of that physician's total gross production, which was about $1.2 million. Then that employed physician, in their contract, they were entitled to 40% of their compensation base. So they're getting paid 40% of whatever they produce. But they agreed to have their personal expenses taken out, which included malpractice premiums, retirement plan, license and dues, health insurance, anything related to that benefits that physician directly. And after you're reducing those expenses, you basically come down to the compensation for that doctor. Mm-hmm. This plan worked out really well because it offered an incentive to that physician to work hard. The harder they worked, the more they got paid. And they had some control over their license and dues and auto expenses and other things, so they could keep some of their costs down if they wanted to make more money or whatever it was. So this was a plan that we helped design for a group, and it worked out really well for both the owner of the practice and for the employed physician.
Yeah, this plan is a great design if your non-owner physician is willing to put it all on the line and risk it all, because there's no guaranteed base comp here.
Right.
You know, it's a straight out 40% of what's going on.
And you may want to go to a guaranteed salary for 1 or 2 years and then have an understanding that we're going to move to a model like this in year 3 and going forward.
Yeah, and this one uses, you know, the number 40%. The 40% is not a magic number for any practice. 40% was probably, in Say's example, enough for them to still make a profit on this physician on their individual monies. So they probably were making 60% on every dollar. They took 20%. The physician took 40%.
Right. We knew what the practice overhead was.
Yep.
So we had to set that compensation percentage for the employed physician at a spot that would give that physician adequate compensation, but would also leave some on the table for the practice owner to get something out of, you know, taking a gamble on employing this doctor. So depending on how profitable the practice is, that number may be higher or lower.
Yeah, that's a great example. That's a great way to incentivize your non-owner physician. This is a great way to incentivize some of your other mid-level providers too, if they're willing to do it and you're willing to back into the numbers. So you could do it with a nurse practitioner. You could give them either a strict out, you know, pay for what you do. You could give them some incentive to see patients. It works well not only for physicians but for your physician extenders or your mid-level providers. That's a great example. We want to talk about, there's other ways to look at this, and there's a lot of numbers on these pages, but we're going to talk about these people here wanted to have people actually be on call. So at this point in level 1, box 1, I'm not going to go through the rest of it, they actually give what they call work unit points for people on call. So they all dump in, you can see here, these 4 physicians put $120,000 up into what they call points. And if you work a day, you got 1 point. If you were on call, you got half a point. And it incentivizes actually people to show up to work, because $480,000 worth of comp for this whole practice was being split up on who actually showed up for work, days in clinic, and for on the amount of days they took call. So it's a little bit of a different model. The only other thing I guess I would point out here is, I don't think there's anything else I'd point out there. It's a pretty straightforward, and this is a completely variable model. They pay overhead. If you see down at the bottom of compensation level 2, right above that, less overhead based on unadjusted collection percentage. So this is a completely variable model. It pays out, the guy who put out $2.2 million is paying $1.6 million in overhead, versus the guy that put out $1.4 million in collections is only paying $1.1. So a $500,000 swing in overhead, that's a big number. But this is completely variable all the way across the board. So the problem with that is that it has the exact opposite of what we would do for a fixed. The con here is that the large producer is paying a large amount of the overhead, and probably a lot of it's, you know, he's paying more than his fair share in probably his perspective. So I would say that these are points that I think if you're working through your partners or coming up with a model, you probably need to bring somebody in to do a little strategic planning with you. This isn't something that your office manager can talk about with your physicians. They have a valued role in your practice and they're trying to preserve their job. I would tell you to bring someone in, individually meet with each one of you guys, the physicians, and get their take on what they think is a fair compensation model. And once somebody like Say or myself talk to every one of the physicians and figure out what's important to them, what's not important to them on the compensation model, we can put together a model that helps suits everybody's wanted perspectives. And we didn't say it's going to be fair, but it'll be fair. But we won't say everybody will be happy, but we can at least see what's important to people, and that often helps out. They don't want to speak up in a crowd. They may be the younger physician. An individual consultation and then a group meeting works pretty well, especially if you were fighting about a compensation model. So did you want to talk about this compensation model right here?
Yeah, I'll just go over it real quick. This was a 3-doctor group. It's a kind of a mixed plan compensation formula. Each doctor has their production, and then their compensation base is reduced by their direct expenses like their salary and taxes and licenses and malpractice and all the things that we've talked about already. But their remaining overhead, half of it is split evenly among the doctors, and then the remaining half is split based on their percentage of production. It works well for this practice. That's just another example of, it's a mixed formula, like I said. So that works well for that practice, but
Yeah. I want to talk about one other thing. Our information's up there in case you come up with some questions or want to shoot questions, or if you want to jot it down. But the other model that we didn't talk about right now that's getting a lot of hype and has been for in the hospital setting for some time is RVU models. And we're seeing a lot of questions related to how does the RVU model work. The hospital has been using the RVU model for quite some time. That's the relative value unit. And each procedure, each CPT has an assigned RVU to it. It's not based on payer at all. It doesn't matter what the payer is that procedure. So if it's a colonoscopy, it has a set charge. It doesn't matter if it's Blue Cross or Aetna or Cigna or Medicare, it's worth an RVU, relative value unit. The way the relative value unit works is that since there isn't any production collections related to it, RVUs are benchmarked on a schedule. So if you work and you produce 3,000 RVUs, that's tied to a benchmark salary based on your specialty. So 3,000 units may bring in, your compensation will be $250,000. Whereas 5,000 RVUs, and it's not based on a one-for-one type of thing, you might be paid $450,000. And so as you produce more RVUs, obviously you're going to be paid more. In the hospital setting, it works perfectly. In private practice, a lot of people are starting to go to it to keep payer mix out. They're usually doing it for someone coming out of a hospital setting. So I have a client who wants to bring someone out of a hospital setting. All they know is RVUs. So we set up a model and told them, if you produce this amount of RVUs, you get paid this. If you produce this amount of RVUs, you get paid this. Of course, you're only going to pay about 60% of about a mid-level payment benchmark schedule, and then you'll make up bonuses as they hit those levels so that you don't overpay as you go forward. So you guarantee an amount, and then when they hit it, at the end of the day, you pay that amount. The problem with that, the only problem in private practice is that if you put someone on an RVU model or you're looking at an RVU model, your payer mix becomes irrelevant because it doesn't matter. That could be good, potentially, if everybody's kind of splitting in stuff. It could also be bad because we know that payer mix is an important part, an important mix to your practice. If you're seeing in Alabama, if you're an OBGYN and doing Medicaid all day long and baby deliveries, that's going to pay you about 2/3 of what it would for a commercial contract. And if you're just worried about RVUs, you won't worry about your payer mix. It usually works a lot better when you have someone that you're paying on a non-owner level, someone that you can tie that money to, and it doesn't. You're still going to make a profit margin on them regardless. And you want them to work hard. You don't want them to worry about who are my patient mix and who am I seeing today? Is this a Medicaid patient or not? You just want them to see patients and get paid on that. So that's a new trend. The RVU model is a new trend. Well, we're about an hour in, and that pretty much concludes our series. I don't see any questions saved. Do you see any questions?
No questions.
Does anybody in our room full of participants have any questions tonight? All right, well, I don't see that we have
They're all raising their hands.
They're all raising their hand. I don't see that we have any hands from our participants tonight. We appreciate y'all coming. I don't know the date for the next one, but we do have number 4 and number 5 coming up soon. If you have any questions in the meantime that we can help answer, or even if we can address on our next conference call, our next webinar, or even in person, we'll be happy to help you with that. Again, our information is listed here. Feel free to call, reach out at any time. We'll be happy to talk to you and work you through any questions that you have. Again, thank you for our sponsors, Southern Medical Association, Southern Medical Services, Jefferson County Medical Society, and Warren Averett for help putting on the presentation tonight. And we will see you next time.